morning. Good morning. Now we shall start with next session, which will be gout advances. Gout distinguishes itself in the history of Homo sapiens since the time immemorial. It was first identified by Egyptians in 1640 BC. It is one of the most understood and well described arthritis, but being well neglected by the patient itself. Out of curiosity, I would like to show one slide from one of my patients. I'm from Arunachal, where our customs and tradition is alcohol and meat consumption. So this is one of my patients who came with polyarthritis with this kind of presentation with so much of distraction and topices gout. So here you can see the x-rays, multiple distractions, ulcerated with chalky materials, and this is the presentation which I got from Arunachal. So to chair this session, with due honor and respect, I would like to invite our chairperson, Sir Dr. Jose Paulo P. Lorenzo from Philippines. Thank you, sir. And Dr. Molly Taba from Puducherry. Ma'am, please.
Hello, good
Thank
morning.
you.
Thank you.
So, good morning, everyone. Our first speaker is around to give a talk on update on gout guidelines. Dr. Sami Salman. I saw him in the next hall, so I know he's physically present in the building.
Yes. Can we call Professor Sami Salman, please? Or sir is on the way. Yes. Oh no, that's Professor Terran Gibson.
This is Professor Gibson. Yeah, welcome, Professor. We're missing Professor Salman, Sami Salman. So would you be ready to give your talk?
I noticed the first people are heading downstairs for
For coffee.
coffee. Yeah, I went down to breakfast. I was on the building of the development party downstairs. So the audience downstairs.
Okay.
Is it worth waiting on the
2 minutes, maybe. Yes, we can.
And hopefully Professor Salman will be on his way back from the coffee break.
Oh yeah, we were supposed to begin at 10:15. That's the reason.
This is now.
We are like
We're 5 minutes
5 minutes
late.
late.
Oh, there he is.
He has arrived right.
This is Professor Sami Salman.
You can keep your coffee here, sir. This place.
So Professor Sami Salman, Professor Emeritus from the College of Medicine, University of Baghdad. You have the floor, sir.
Thank you. Actually, I'm delighted and honored to be among you. It's one of the best conferences that I attend year round. And my love to this country is beyond any description. So actually, this is an Aman star, and the person next to me is Justin Mason. And Justin Mason, we visited the temple there, and few months ago, I needed him to send me an article. So I wrote to him, please Justin, can you send me this particular article? I can't get hold of it. Then I received a letter from his secretary saying, sorry to tell you, he passed away.
Oh.
So Justin Mason was one of the people who were born of this country, and he visited India so many times. He is a great vasculitis person, and I'm sure Aman Sharma was really, very, sad for his passing. And this picture, this photo is, you can see the first person is the chairman, so that's Paolo Lorenzo, and the third person is Sayyid Atiq al-Haq, and myself. We are having a nice coconut water in Bangladesh, and it just happens by accident that all three of us are part of the steering committee for putting the guidelines for gout. That was published in the International Journal of Rheumatology. So the steering committee was sort of a hierarchy of sort of technical staff who really were searching all the papers worldwide, and the other part were studying the evidences and putting the recommendations. So that for the asymptomatic hyperuricemia, which people keep asking us, is that among patients with asymptomatic hyperuricemia and hypertension, we recommend against urate-lowering therapy in patients to reduce the risk of major cardiovascular events or mortality, because of the 10 randomized controlled studies, there was inconclusive evidence that urate-lowering therapy makes any difference to MACE. And again, I mean, for chronic kidney disease with asymptomatic hyperuricemia, again, the same recommendation is valid, that it was against using urate-lowering therapy. So for treatment of acute gout, and the recommendation was the same usual thing that we have been taught in medical schools, that colchicine is the number one drug to be used there. Non-steroidal comes next, and sometimes systemic corticosteroids. All three probably are first line. And in acute gout, the recommendation here is that we should use the low dose colchicine, probably 1.5 to 1.8 milligrams per day. So that comes in countries who had the dose of 0.6 3 times daily, and in my country where it is 0.5 milligram 3 times daily, against the previous recommendations where they keep loading the person with the colchicine until he gets diarrhea and until he gets side effects. This is no more valid. And again, in acute gout arthritis, there is not sufficient evidence to inject the joint. I mean, no randomized controlled trials were available to be studied. And the publications about this was really very low quality publications with no randomization. Again, in acute gout and the treatment of urate-lowering therapy naive patients with gout, there is again insufficient evidence to recommend initiating the urate-lowering therapy, i.e. whether you are using allopurinol or you are a fan of febuxostat during the acute gout flare over after the flare. You know the previous recommendations, they say wait until the flare subsides completely, and then you start with the allopurinol or with febuxostat. Actually, the studies, there are 6 randomized controlled trials, did not show conclusive evidence for increased gout recurrence or for pain when you start during the attack. So you don't need to wait. I mean, once you are sure this is an acute attack of gout, you can actually give the patient the urate-lowering whichever you favor, whether it is allopurinol or glucosidone. Prophylaxis against flare when initiating urate lowering therapy. And again, this is the same recommendation that has been held before, is that you should start a patient with colchicine and he should stay on it for 3 to 6 months at least. Again, this is one measure that you are doing to prevent an acute exacerbation, because previous so many studies have proved that you need a prophylactic colchicine while you are starting the patient on urate lowering therapy. Again, low dose. You don't need a high dose, and probably colchicine of 0.6 milligram per day or 0.5 milligrams TID for 6 months. Then you can stop the colchicine and continue with the urate lowering therapy. However, some people are intolerant to colchicine, or there are some contraindication to it, and then NSAID can be used, and again for the same duration of that we mentioned, 3 to 6 months. Of course, some people would feel a bit worried about keeping a patient on NSAID for 6 months just because you have put him on urate lowering therapy. But this sort of probably protects him from getting an acute attack while he is loading with the urate lowering therapy. And there was some question, what happens if we cannot give colchicine and we cannot give NSAIDs? Shall we give steroids? And the recommendation is that there is insufficient evidence to recommend for or against the use of systemic corticosteroids as a prophylaxis. So for this, we cannot really give an answer. We wait probably for more papers, good papers, to tell us if we need to put the patient on steroid during these months. Urate lowering therapies, I remember one of my students saying to me, I was going to put a patient personally, going to put him on allopurinol, and he said, Prof, why didn't you send him for HLA-B 5801? I said, what? And he said, you need to do this test for the patient before starting allopurinol. I said, I never heard of it. And then I checked that there is a very small population, mainly in Southeast Asia, that small population that have got this gene, and that these people are prone to develop serious, severe cutaneous adverse reactions if they take allopurinol. But for the rest of our countries, and even in India and in my country, we don't have this population. And so probably those countries where there is this allele, then yes, it is worth testing. And it's not available even in my country, this testing, and we never really needed it. And I'm repeating that among gout population with high prevalence of HLA-B 5801, the recommendation is that we neither recommend for or against febuxostat over allopurinol. The reason is that the first reports, they were mainly concentrating on allopurinol, that it is causing the severe skin reactions. However, there are some other papers that were mentioning that it's not that high, and it's not, and that we can use either one. Again, urate lowering therapy. When do we start it? When should we start it in a gout patient? And the newly diagnosed gout patients, the number that we actually put is 9 milligrams per deciliter, that it is worth putting the patient. You are giving him something lifelong. It's not like the practice that some of our colleagues do. they put the patient for only few months or only few weeks even. I mean, you are going to put sentencing for life. So probably it's worth when his serum uric acid is 9 and above. Less than that, there is the evidence that probably you don't need actually. Of course, other considerations for recommendations from other guidelines. Cost is also important for maintaining urate lowering therapy, except for a lower serum uric acid. Many people cannot, they pay from their own pocket, and this might really very costly to them. Chronic tophaceous gout, and among patients with chronic tophaceous gout, we recommend the use of xanthine oxidase inhibitor, whether allopurinol or febuxostat, over non-urate lowering to achieve resolution of tophi. So they should be used for chronic tophaceous gout. And among the chronic tophaceous gout, patients with serum uric acid above 6 milligrams, we suggested against using lesinuride to xanthine oxidase inhibitor for resolution of the tophi. Complicated gout and non-responders, and among adults with refractory gout. And these refractory gout are those who continue to have a high serum uric acid despite treatment. And there is insufficient evidence to recommend a uricose uric agent and xanthine oxidase inhibitor in combination, other than the one that is studied well, which is lesinuride allopurinol combination, to achieve target serum uric acid levels and to reduce the gout flares. So this combination has got 3 randomized controlled trials for the effectiveness of the combination of lesinuride and allopurinol. And among adults with refractory gout who have contraindication to xanthine oxidase, we suggest pegloticase if available, because many of these countries, including mine, they don't have pegloticase to achieve a target serum uric acid. And in moderate to severe renal impairment, and these patients with gout and renal impairment, there is insufficient evidence to recommend for or against the use of urate lowering therapy to prevent chronic kidney disease progression. And it showed that whether you give them urate lowering or not, it ends up the same, I mean, in terms of prognosis. The non-pharma, and I'll go quickly, limiting alcohol intake, limiting the purine-rich. This is, I mean, almost like our bread and butter recommendation that they should try not to limit both alcohol and the purine-rich diet. And weight reduction is very important. And some patients, I mean, acupuncture may be an option if they continue to have pain. And there are some 7 studies of the use of acupuncture for the pain mainly. And there are some studies on herbal medicines. We couldn't make any recommendation. There was very low confidence of evidence, and our phase 1, most of them have Chinese name, yellow dragon, a wonderful seed, formula, compound, toppling. There are studies on them, but we could not really make sure whether we can recommend them or not. So there was no recommendation. So thank you for listening.
Thank you, Professor Sami Salman. We request you to join us here. Meanwhile, the next speaker would be Professor Terence Gibson. Sir will be speaking on acute challenges of geriatric rheumatology, that is gout and beyond. Over to you, sir, to start the talk.
Thank you very much.
Thank you so much. Thank you very much.
At present, a huge amount of speculation about how hyperuricemia and gout can affect other organs, and much of it is based on rather weak evidence. And so I've decided to stick to what we know, raising some questions about what we don't know, and make some allusions to some of the rather wilder theories about how hyperuricemia can affect other organs as we go along. So I'm going to go back to basics. So this is a back to the future talk, if you like. So I'm going to touch on biochemistry, physiology, pathology, and pharmacology. Actually, pharmacology I'll leave out because you've just had enough of that from my esteemed colleague here. But knowing about the basis of gout has helped us to develop the treatments. It's worth noting that this is a disease that's on the increase throughout the world as people become more prosperous. And despite its ancient history, it continues to attract interest. And even in last week's New England Journal of Medicine, a whole article devoted to the subject from A to Z. I'm going to talk a little bit about the formation of urate crystals because that's where we started. Urate crystals are what we deal with mainly in clinical practice. There are things we do know and there are things we don't know about the way the crystals form and where they form. First of all, a little basic biochemistry, which is recently fed into the theories. For example, we know that xanthine oxidase is an important part of this process of eliminating purine waste products. And xanthine oxidase can cause the development of reactive oxygen species, and some would claim that this is the reason why you have damage to the kidneys, possibly the heart, and other tissues. But the evidence is so weak. But even xanthine oxidase has been dragged into this discussion about how uric acid alone can be a cause of inflammation and damage organs outside the joint. So there's no doubt at all in anyone's mind that gout is caused by the crystals of monosodium urate, and they're liberated into the joint for one reason or another. So MSU, monosodium urate, is an interesting product of purine degradation. It exists side by side with disodium urate, but which tends to be innocent because it is much more soluble. Uric acid then is the end product of purine degradation, and most of it is endogenous, and we derive a small amount from our diet, and it's a feature of metabolism in primate birds and even some reptiles. Just a little bit basic biochemistry. Uric acid, then you see its formula here, it's a weak acid. Monosodium urate displaces one of the hydrogen ions with sodium, and disodium, two sodiums for two hydrogen atoms. In the blood, uric acid circulates as monosodium urate, and in the urine as uric acid. Important to note that MSU is much less soluble than disodium and uric acid, and it tends to be influenced by temperature more than any changes in body pH. And that may explain partially the fact that you see tophi in the extremities, end of your fingers, over the pinny, on your toes, in your code of extremities. Maybe. Just switching to some basic physiology then. So most patients who have a history of gout have a relative low renal uric acid clearance. And this has generated a lot of interest about the causation of hyperuricemia itself. I've had the opportunity to live in New Zealand and study the Maori people there who have an exceptionally high level of gout and hyperuricemia. And one of the pivotal studies that I did while I was living there was to look at their urate clearance, and it's exceptionally low compared with the European population who live in New Zealand. And that's interesting. It raises questions about the handling of uric acid by the kidneys. And This is a patient from that Maori population who has chronic tophaceous gout. And we've got to know a lot about the way the kidneys excrete uric acid. And it's highly dependent upon a flow one way and another in the proximal renal tubules. And that flow is dependent upon renal urate transporters, for which there are several. And each of these can be identified with specific genes. And so it was thought that maybe those under-excretors who constitute the majority of people with gout, and especially looking at the Polynesian population, we will find evidence that genetic variations account for the impaired urate clearance. But we haven't discovered that, you know. We're using genome-wide searches. There have been lots and lots of mutations within the gouty population of a number of the genes known to be related to urate transporters, but no consistency. And some of those mutations associated with hypouricemia or hyperuricemia. But in the Polynesian population, for example, where it was hoped that we would find a specific gene or gene mutation to account for this amazing predisposition to hyperuricemia, it simply hasn't occurred. So it's probably multifactorial. So there clearly is a lot more exploration to be done here. In general, URAT1, which is one of several urate transporters, is considered to be the most important. But again, in isolation, it doesn't explain the low urate clearance that we see in so many patients with gout and in this Polynesian population. So in this series of 69 patients with primary gout, it was possible to demonstrate 6 different mutations, in 23% of people. No consistency. But the same mutations were also seen in people who didn't have gout. And so this is almost like a dead end. Just say a little bit more about the kidneys in relation to young people with gout. Very important to consider uromodulin-associated kidney disease when children or adolescents present with gout. So this is a clearly genetic abnormality that is associated with kidney failure. Most of these patients end up having renal transplants at a young age. And the other reason where you might encounter gout in young people, of course, is HPRT1 enzyme deficiency. Right at the beginning, one of my slides showed you the importance of the HPRT enzyme in the process of recirculating uric acid. So if it's missing, that process, the so-called salvage pathway, doesn't occur. So you have a build-up uric acid, it's not recirculated, as it were, back into the purine pathway, and you get gout and kidney failure. And when it's completely absent, the Lesch-Nyhan syndrome, which is associated with neurological abnormalities, which raises other questions about the link between uric acid, urate, and the nervous system, but you can leave that apart. Neurological symptoms and sadly early death in these children. A little bit about urate crystals then, just turning back to the crystal itself. It's, I've tried to configure it here. You've got uric acid, urate linked with a molecule of sodium and water, and it forms this sort of lattice. And the formation of crystals is, as is obvious, highly dependent upon the concentration of the monosodium urate in the circulation. But crystal formation and the urate have a predisposition to collect on areas of collagen. They have this affinity for each other. And in laboratory studies, it's been shown that you're going to get crystallization if you expose high concentrations of monosodium urate to cartilage derivatives containing collagen. And interestingly, when you put monosodium urate into synovial fluid from gout patients, crystal formation, again, is more likely. So we think that this affinity for crystallization in collagen accounts for the distribution that we see in patients with gout. And where cartilage is already damaged and exposing the underlying collagen, you're more likely to have accretions of crystals. And the process is one of primary nucleation on the cartilage, and then on top of the initial layer of crystals, more crystals develop because they have a similar structure. I've used some of the crystal terminology there, but I don't want to even try and explain what these mean. I'm just showing you now how collagen is arranged in cartilage in these sort of wonderful parallel bundles. And when you stain cartilage for uric acid, you see the same sort of pattern. So what I'm showing you here is how monosodium urate crystallizes out in collagen in cartilage and is aligned precisely with those lovely bundles of collagen that I illustrated a moment ago. So when a joint is damaged, as you see on the right-hand side here, exposing the underlying cartilage and thereby the collagen, you're more likely to have crystals developing, which may well explain, and probably does explain, some of the distribution of tophi. So this is what happens when you have a lot of, when you have hyperuricemia and crystals begin to develop. They lie on the joint surface, as you can see through the arthroscope on the right. On the left, electron microscopy of layers of monosodium urate just lying there benignly on the cartilage. And this is almost certainly the process which has taken place in this patient here who's got a tophus overlying a Heberden's node. So where there's a damaged joint at an Heberden's node, then crystal formation is started and developed until you get this tophus. So in brief, I've spoken about reduced solubility, aggregation of monosodium urate, nucleation, and then crystal growth. And here we are, the agents of destruction, sodium urate crystals themselves. So we know then when these are liberated into the joint cavity for one reason or another, like a falling urate which upsets the homeostasis, or trauma, then the crystals are ingested by synovial macrophages, and there's an influx of leukocytes which continue ingesting the crystals, and they stimulate that inflammasome cascade, which generates very, very severe inflammation. The sort of inflammation, and the same sequence that you see in familial Mediterranean fever and adult onset stills and a number of other diseases. Ever so briefly now, this is where much of the interest lies, and what I suspected the organizers wanted me to talk about, but huge amounts of this is speculative. We know for sure that hyperuricemia and gout tend to be the associates of plenty, to quote, in other words, a healthy but overindulgent diet. Obesity, there's no doubt there's a relationship with the level of your urate, and that probably operates through the insulin effect. As you increase your body fat, the insulin level rises, and insulin will, to an extent, impair urate clearance. Then the association with hypertension. Now, I just emphasize that these are associations, and cause and effects remain to be established. And there are many people, as I alluded to a little earlier, who are trying to turn what we know about uric acid and monosodium urate into explanations for why we have these associations, but they're actually probably multifactorial. I don't want to refer to any of the studies that I've done decades ago, which point to the fact that the way we live is probably more important. My last slide dealt with the treatment of that, but just continuing down this list of things, chronic kidney disease, alcoholic stress, which used to be thought reduced urate clearance, but studies which I did myself many years ago showed it actually stimulates purine production and overproduction of uric acid. We all know that diuretics, with the exception of spironolactone, probably impair renal tubular secretion because they compete with binding sites with those urate, tubular renal urate clearance sites. And then the question of hypertriglyceridemia. Hypertriglyceridemia has an interesting history in relation to coronary artery disease. That's, in the gouty context, it's certainly related strongly to alcohol and to obesity. Whether other factors involved remain unknown, but probably not. Whether that accounts for the weak association with coronary artery disease remains to be seen. There are some who believe, I've mentioned the crystal formation because that argument too has been taken to the coronary arteries, and there's no doubt that some studies have shown that crystals can be found in the coronary arteries. As I said, they have an affinity for collagen, and collagen lies within the vessels. And in fact, dual energy CT studies have shown that urate crystals can be found in many, many sites, but it's completely unknown whether they are in any way associated with inflammation or diseases in the organs where they're found. So I've covered as much ground as I can. As I said, my last slide was to do with treatments, but you've already heard how gout should now be handled, and so I'm going to stop there and answer any questions you might have. Thank you very much.
Thank you, Professor Gibson. If you'd kindly join us in the front. So I'm going to open the floor. We have a few minutes for questions. Yes, we have a question from Dr. YK.
Yeah, Mike Tess, Professor Salman, nice to meet you finally. We see each other on Zoom, but now I see you in person. So it's not a question, but just a clarification that the HLA 5801 not only affects a few countries in Southeast Asia. The HLA 5801 was discovered by a Taiwanese dermatology in the Han Chinese. So the Han Chinese is about maybe if you look at in China alone, is more than 1 billion people having the genes. So it's not a few countries. And if you look at the Chinese diaspora, it'll probably be a lot of people with the it's about 20% prevalence of the HLA 5801. But the positive predictive value of hypersensitivity is, even if you have that gene, is about 2 to 3%. So just a little clarification. Thank you.
Thank you for the clarification. That's wonderful.
Any more comments, questions? Yes, sir.
I'm Dr. Paramjit Singh from Iracon. I'm Dr. Paramjit Singh from Iracon. I wanted to ask, in the urate lowering therapy, which agent do you prefer, like allopurinol or tamoxifen? You have given the recommendations, like any of them can be preferred. We have any cardiovascular risk factors also associated with tamoxifen?
It's a very nice question, actually. Thank you. To be honest, I mean, during our guidelines, we did not find a preference. I mean, previously there was sort of more promoted febuxostat for people with CKD, but then there was some sort of warning now about febuxostat in terms of cardiovascular probably events. So altogether, I personally, I would leave it to the treating doctor to decide, but I wouldn't put any weight for one of them against the other. Personally, I still use the allopurinol, which I'm used to use, and I'm confident in it.
Thank you.
Thank you.
Yes, I'm Dr. Ravichandran from Chennai. What is the maximum recommended dose for febuxostat? That is question number one. Is there any drug that reduces the tophus formation once they are formed? Is there any drug that reduces the tophi?
Yes, thank you. May I really beg you to go to our recommendations. You will find the answer there is very clear how to deal with tophaceous gout. I had to go quickly because I had 30 slides. But again, the allopurinol, the urate lowering therapy, is good. And it does definitely reduce the size of tophi, and even some tophi disappear. Febuxostat itself is good, and again, it causes a reduction of both the size and the number of tophi. What else did I want to? Oh, the maximum dose. At least in the references that we went through and the publications, they mentioned 120 milligrams of daily of febuxostat. The papers did not mention any higher dose. I don't know if this is for you. It's okay. Yeah. Thank you.
I think we one more question. We have time for one last question.
I would like to ask one question to Professor Terence Gibson. Sir, you had mentioned about GWAS studies in gout. Whether any specific data is there on doing GWAS in young onset gout, sir?
Well, I've drawn attention to the only genetic related illnesses that we do I don't recognize, but there may be others. And yes, perhaps that has already been done, but I'm not aware.
Yes.
May I make a short comment for our students or postgrad students, and that tophus in Latin means chalk stone, chalk. And during the Victorian ages, the British, the grandparents of Alan Dixon, of Terry, they all had very good food, and they all drank a lot of whiskey because it was an empire where the sun never sets, and so they were rich. And when they play their favorite game, which is snooker, and they don't find a chalk, they all use the tophi that they have in their fingers. So how much the scoring? 1, and he scores with the tophus in his fingers. So his chalk is from his own person. Just for a joke. Thank you.
Well, thank you, Professor Salman, for that little anecdote. So I think we end this part of the session, and I'd like to thank Professor Sami Salman and Professor Terence James Gibson for spending a few minutes with us to talk on the topic of gout.
Thank you.
Thank you very much, sirs. We go now to brainstorming.
Yes.
Okay, so
She will be speaking.
so we'll now we can ask Dr. Kriti Kishore to come up. You have the floor.
Kirti will be speaking on young onset versus geriatric onset gout in Asians. The question is whether both diseases are on the same side of autoinflammation. You may begin, Kirti.
Good morning, everyone. So today I'll be speaking on young onset versus geriatric onset gout amongst Asians. And so what are the important questions that need to be addressed as far as young onset and geriatric onset gout is concerned? So are young people with gout more likely to be overproducers as compared to underexcretors? do genetic polymorphisms affect urate levels in young? Whether there is a difference in clinical presentation in both these scenarios, whether there is a difference in serum urate levels between the young and geriatric onset gout, does early onset gout increase risk for metabolic syndrome, does early onset gout increase the risk for tophi formation, and whether the renal function in older people determine the serum urate levels, and what is the role of various comorbidities in determining serum urate and its risk for progression. So before we move on to the pathogenesis, this is a graph from a recent publication which derived its data from the WHO database on gout and comorbidities. So according to this data, the incidence of gout worldwide currently is around 0.097% with a prevalence of around 0.54%. And as we can see in this graph, there is a linear increase of incidence as well as prevalence with aging until the age of 64 years, and then it declines, and then there is a second peak after the age of 80 years. As has been mentioned by previous speakers also, that the incidence and prevalence might be far higher in Asian countries such as India and Taiwan, and especially in patients above the age of 60-65 years, it can be as high as 9 to 10%. And so why is uric acid in children or young onset gout important? So there is coming up literature that says that children with hyperuricemia are more likely to progress to adult onset hyperuricemia. They are more likely to have adult gout, and also it increases the risk of atherosclerosis and metabolic syndrome in children. So that's the requirement for us to know whether or not we can do something about it, and what are the differences between a young onset gout and an adult onset gout. So we all are aware of the pathogenic mechanisms and the various interplay of factors that take place in gout. So we know we have dietary factors such as purine-rich foods, we have alcohol, and the serum-free fatty acids are known to activate the TLR receptor 2, further leading to formation of IL-1 beta. And also the complement coated MSU crystals, they can directly activate the inflammasome, leading to IL-1 beta formation. And also some interaction with netosis. And so basically it's a balance between the various pro-inflammatory factors and the anti-inflammatory factors. The question now arises is the autoinflammation difference in young onset and adult onset gout? So the current literature has not addressed this question as of yet. But yes, the genetic polymorphisms, as Sir had also mentioned, there are a large number of studies which have seen mutations in urate1, NPT1, and even in GLUT9 in young patients. They have been reported more oftenly, but yes, they have also been reported in adult patients. But since adult patients have other risk factors also for gout, I think they tend to be more overlooked in adult patients. But as for now, we know that these mutations, especially urate1 and NPT1, are common causes of hyperuricemia in young patients. So the newer classification, the traditional classification, classified all gout patients as either overproducers or under-excretors. So now we have a newer classification which says that you can classify them as either a renal overload type, which can be further classified as an overproduction type, or an extra-renal under-excretion type. For example, ABCG2 dysfunction in the gut and in various intestinal diseases. Then we have the renal under-excretion type and the combined type, which have factors affecting both renal overload and renal under-excretion. So various causes of hyperuricemia in young. We have hyperproliferative states such as ALL or a tumor-Lucis syndrome. We have inborn error of metabolism such as a Lesch-Nyhan disease or a partial HPRT deficiency, cyanotic congenital heart disease with secondary polycythemia, genetic mutations, infections, dehydrations, drugs such as valproate or theophylline, and even obesity. But when we come to factors determining renal urate excretion in elderly, drugs, I think, is one of something which is very common in the clinical scenario. So we have low-dose aspirin, thiazides, loop diuretics, we have NSAIDs and levodopa. Among renal causes, we have chronic renal failure, which can be due to any etiology, hypertension, and various endocrine or metabolic causes such as obesity, hyperparathyroidism, and even dehydration. This was a study done in CMC Vellore from Dr. Danda. So they looked at clinical profile of young onset gout in India. So they found that most patients were under secretors of uric acid with higher incidence of renal calculus. Polyarticular gout was more frequently in elderly and females, and it had a greater association with tophi, with renal calculi, renal dysfunction, and ischemic heart disease. Diabetes, hypertension, and obesity were more frequent in oligoarticular gout. And the young onset gout was characterized by acute intermittent polyarthritis. They had lesser episodes of podagra, and they had early tophi formation. And then there was this another study from Taiwan who also looked at young onset gout, which they defined as age less than 30. So they found that the first attack frequently occurred between the third and the fifth decades in around 70% of the patients, and that the patients, females, even the incidence had increased in female patients. Coming to my last slide, which basically summarizes the main clinical differences between young onset and elderly onset gout. So the young onset gout is more frequent in females as compared to in elderly onset gout, which have almost an equal incidence between males and females, and especially in postmenopausal females. Asymmetrical lower limb involvement and a monoarticular onset is more common in young onset gout, while elderly people with gout can have a symmetrical or polyarticular involvement at onset. They can have upper limb joint involvement, and it can be of insidious onset also. The attacks of podagra, which are more commonly seen in young onset gout as compared to elderly onset gout. And tophi per se are rare in young onset gout and are more common in elderly onset gout. Thank you.
Thank you, Kirti, for that presentation. I'm supposed to give the words of wisdom, but I don't think I have any because I'm not really an expert in gout. If I may ask maybe Professor Terence Gibson to just tell us in this to us whether his experience in the management and approach to a person who has young onset gout. Sir, please. Can you give the microphone to Sir, please?
Well, the first step is to raise the question of why. And it's if a young person, we're talking about adolescents and children who have
Yes.
gout, very, very important to explore the possibility of a genetic aberration, and then to look at the family. Just giving a bit of historical information, I was involved in exploring one family in the UK way back in the early 80s, and then we called it juvenile onset gout, and they all developed renal dysfunction. And these were patients who had a uromodulin gene deficiency, but at that time it simply wasn't recognized. It is perfectly possible that there remain genetic abnormalities, as I alluded to a little earlier, that account for gout as it crops up sporadically in populations. So first of all, look carefully at the family. Look to see whether there are any comorbidities, and look at the kidneys in particular. So having established that, and even so I may say that in the 80s, 70s and 80s, the theory was that these children were hyperuricemic, and the hyperuricemia was damaging the kidneys, not the other way around. And so the emphasis was on treating their hyperuricemia. It gradually dawned on us that as you got the uric acid level down, the kidney disease progressed. So clearly we got that one wrong, and that was at a time when it was held that hyperuricemia was damaging to the kidneys. And I know that idea was crept back into our discussion. But coming back to your question, it is possible in all these children to get the uric acid level down using allopurinol. in a standard dose. So that would be my approach, having excluded any underlying genetic abnormality, explored that possibility in the family. So beyond that, they just need careful supervision with reference to the kidneys and the other organs too. But always keeping open the possibility that you're dealing with some new, previously unrecognized phenomenon.
Thank you, sir.
Thank you, Professor. Can I have a follow-up question? So, what happened with the to you, sir?
Professor Gibson, then Professor Sukumar Mukherjee.
Okay. So, what happened? So, you got the uric acid fixed, and then they developed kidney disease. And did they identify what particular kidney disease was taking place? Did they do biopsies? Did they any nephritis that was identified?
Okay. So biopsies were undertaken, and of course, in early adulthood, all of the children in the family that I studied had renal transplants successfully. Biopsies and the kidneys showed a lot of interstitial fibrosis, but there was no specific histopathological change that you could identify that made it, something easy to diagnose on the basis of a biopsy. So they just showed kidneys that were badly damaged. As I said, I outlined the history for you as best I could. It's uromodulin is an interesting molecule, and I'm not going to discuss that now, but if you go to the literature, you find it's a fascinating renoprotective part of the anatomy of the kidney, and when it's missing, this is what can happen.
Thank you,
Thank
sir.
you.
Can I ask a question?
Professor, please.
Yeah,
Then
so-
Professor Sukumar Mukherjee first.
Sure.
Just a minute, please,
okay,
sir.
sure.
Sir, please. Professor Mukherjee.
Is there any threshold of serum uric acid with the formation of tophi? This is one. And second, I have got a very difficult patient of chronic kidney disease with the renal failure. And he is having recurrent gout in spite of the urate lowering therapy. How to handle this situation?
Professor Salman can answer that. Or you would like to answer? Yes, sir.
No,
You can-
let's
Yes. Professor Lorenzo can also respond to that later.
Oh, that's great. Thank you. Thank you, Lorenzo, for helping me with these both difficult questions. The first one was, is there a threshold for tophi? And actually, I wouldn't say there is so many metabolic cofactors that affect tophi formation, and that's why you can find people with very high uric acid and they never develop tophi, and others they might be just sort of marginally elevated and still they develop tophi. No, I would say as an answer, no, out of at the time being. The other question was
Another question is a patient of CKD with a difficult to treat uric acid problem and gout.
Again, I don't have a ready-made answer for this. Probably I would tend to care for his CKD more properly, more sort of if he needed dialysis or not, if he needs dietary.
No, that has been looked into. Actually, any drug therapy, particularly to control in spite of the...
Yes, but I don't have. Probably Terry has got an answer.
I don't necessarily have an answer, but in that situation, it's a very difficult one. A drug that's worth considering is benzbromarone, which is uric as uric, but it has an intense action and can work in patients with CKD.
dialysis also, the patient is CKD.
For sure.
No, Beclotic is benzbromarone.
Okay, benzbromarone. Yeah, we don't have it.
So I just
Yes, please.
leading to that, actually, I just wanted to ask, since many of the patients are actually under excreta, so it seems like the uricose uric is not in the picture anymore. Why is that so? And as what Professor Gibson has just said, benzbromarone can be used when the CCT is so long it's more than 30. So where do you come into play? Maybe the expert can answer that question. The other thing is with chronic tophaceous gout, I've one or two patients, and I do combine febusostat with allopurinol at a dose of 160 febusostat with allopurinol of 800 milligrams, and there is a difference. So the levels do go down, and I typically will bring it less than 300 micromoles per liter. And I was just asking the expert here, these drugs essentially are xanthine oxidase inhibitor. One is a purine analog and one is a non-purine analog. I've tried to look for the answer, and I don't know why by combining these two you actually bring it down. Maybe the expert here can shed some light on that. I mean, this is off-label use, but anyone have any comments or answer to that question? Thank you.
Well, with your first question, uric osurix definitely can be used. Okay, so we have probenecid and, as mentioned, benzbromarone. It depends on the availability in the country. Okay, and usually, I'm glad to hear that with benzbromarone with chronic kidney disease, we can try to use it as a uric osuric, but we're also cautioned that we have to be sure, at least for probenecid, that the kidney function is good and intact. So we have it. I mean, you can use it. It's definitely available. With regard to your second question, I think we asked that combination of xanthine oxidase inhibitors for urate lowering treatment in the guideline, and we didn't get any answer. There was no data on it. And there was just little data on combination of a xanthine oxidase inhibitor and lesinurad, which is a uric osuric. Unfortunately, that drug has been pulled out of the market. It's not available anymore. But we just included it in our guideline because there was data on it that it did have some effect, but it just wasn't available. But we had to put it. So I don't know. I don't know how we asked that question and there was no answer to it. Thank you.
I think we can close. So we come to the end of the session now. I would like to thank all the speakers, Professor Gibson, Professor Salman, our dear Kirti, and my co-chair, and we'll hand over the session to the next team. Thank you so much. Never mind. But we had a good Thank you so much, sir.
It's so nice to meet you, Molly.
Molly.
Okay, thank you.